Welcome to ATCM, the Emergency Medicine channel. Today we'll be discussing a cardiac case that was presented to our ER. A 21-year-old male was brought to ER with complaints of fever for around 1.5 months. So initial 10-second assessment, patient was conscious, oriented, tachypneic, but he was completely, speaking in full, complete sentences. So we went to the primary survey. His airway was patent. There was no signs of any airway compromise like stridor, pooling of secretion, hoarseness of voice. Coming to breathing, his saturation was 90% in room air with a respiratory rate of 24 per minute. Air entry was bilaterally equal, and there was no crepitations or any wheeze. In view of the saturation of 90%, we had asked for a arterial blood gas to be taken before starting oxygen and was started on O2. So supplemental oxygen was started via face mask at 5 liter, but we could immediately taper it down to a nasal prongs at 2 to 3 liter was required for him. Okay. So coming to circulation part, patient had a pulse rate of...
ABG, what was the report?
ABG was showing hypoxia with a PaO2 of 70, but there was no other, slight respiratory alkalosis.
That was taken with O2 or...?
That was taken without O2, but he was referred from other hospital. So during the transport, he was on O2. So that only the transient period he was without O2. And he had a lactate of 2.8. Other parameters of ABG were fine. Then coming to circulation part, patient had a pulse rate of 101 beats per minute and had a BP of 160 by 50 millimeters of mercury. And patient
160
by 50.
Wide pulse pressure.
What
do you think? Wide pulse pressure. Somebody is saying wide pulse pressure. What are the reasons?
One is aortic regurgitation.
It's the commonest thing. It's a common thing we come across every day.
High output state.
Anemia is the most common thing. High output states like anemia, thyrotoxicosis, beriberi. These are the common causes, but since you told aortic regurgitation, that also can produce wide pulse pressure. Okay.
At this time, we had secured 2 large bore IV cannulas for this patient because patient was sick.
Why, you think that it's aortic regurgitation?
Later we dig the systemic examination and all, then we can look, then otherwise we can look for the peripheral signs also.
Okay, wide pulse pressure and aortic aneurysm, aortic regurgitation, how do they present? What will be the BP?
There will be
aortic regurgitation, normally what is the BP?
On higher side, the systolic will be high.
Systolic will be very high, 160, 190. Diastolic will be very low. But what is the BP here?
Here it was 160 by 50.
160, okay. So it's a wide pulse pressure with a high systolic BP.
Then coming to disability part, he had a GCS of 15 on 15. He had GRBS of 118 milligram per deciliter.
Okay.
Coming to exposure part, patient had a temperature of 101 degree Fahrenheit at that time. So he was febrile. So we had asked.
What is the pulse rate?
It was at 101 to 110, that range.
Okay.
Regular sinus rhythms. Temperature was 101. We had asked to give injection. Already IV cannula was there, so we had asked to give injection paracetamol.
What are the indications of IV paracetamol? Can you tell me? We give for many patients, but
if the
real
patient is having
indications.
Vomiting, can't take
Febrile seizures.
Febrile seizures.
In pregnancy, fever in pregnancy. Then a stroke, MI.
MI or any case where
any cardiac disease, including arrhythmias, cardiac failure. All these things we have to immediately control the temperature. So here, since there is cardiac lesion, it is justifiable that we can give IV. Otherwise, IV is not required in many patients, but we give in many normal patients. Like somebody is having fever, routinely we give IV paracetamol. It's not that indicated. Okay.
This time we had also taken a ECG, sir. The ECG of the patient was showing it was sinus rhythm with a rate of 80 after paracetamol only. So it was around 89-90 range, the rate, and it was showing features of LVH, sir.
LVH.
LVH features was there with the normal axis.
LVH with strain or without strain?
Without strain, there was no T wave inversion in lateral leads.
Okay.
Only LVH.
And there is no left axis deviation?
No left axis
Only
deviation.
LVH by voltage criteria?
Voltage criteria, sir. Only that was there. So we went to the sample history by the time. Like we reassessed the patient. So by the time patient was maintaining saturation more than 95% with 2 to 3 liter O2. His tachycardia was settling and he was not tachypneic and was maintaining airway. So we went to the sample history and secondary survey. So patient is having a history of childhood TB which was treated in childhood. He has no history of any allergies, no history of any chronic medications or any surgical history in the past. And now coming to the current event, the patient had history of fever for around 1.5 months. It was like high spiking fevers, more than 100 degree Fahrenheit was the temperature, and initially he was treated in a local hospital where symptomatic management and some antibiotics were given. Later, since the fever persisted, patient went to another hospital where his infective markers were elevated and blood culture showed streptococcus growth, and hence they did a echocardiography, diagnosed him to have a infective endocarditis and referred him here for further management, sir. So there in that
transthoracic echo. Transthoracic echo, right? Transthoracic echo, right?
Transthoracic or transesophageal?
Transthoracic.
Okay.
Then patient during that hospital stay, he had developed some dyspnea on exertion, but he could do all the activities, and but the fever spike still persisted. He had also complaints of some vomiting, but there was no other complaints of any neurological deficits, no complaints of any headache, joint pains, myalgia, abdominal pain, and there was no history of any other IV drug abuse, tattooing, dental or other invasive procedures for him. So we went with the other examination. So patient, general examination, patient was moderately built and there was the typical features, peripheral signs of infective endocarditis like these splinter hemorrhages, nothing was there.
Okay. Spleen?
Spleen was not palpable,
okay.
sir.
Okay.
So we went with the system-wise examination.
In the eye you will look?
Retinal hemorrhages, road spot, we can look at it. It's a circular hemorrhages. So we went with system examination for this patient. S1, S2 was heard, and there was a pansystolic murmur in the apex, and a diastolic murmur was there in the left sternal border. So these two murmurs were heard. And we went with the chest examination. Air entry was bilaterally equal, and there was no signs of any crepitations. Perabdomen was soft, no organomegaly, no tenderness, and CNS also no focal neurological deficits. And in general examination, there was no elevated JVP and there was no pedal edema.
So clinically, what is this murmur? There is
a pansystolic murmur is because maybe
S1, S2 is heard.
Sir.
So it is basically there is a mistake in when you tell pansystolic murmur. You are not hearing S1. It is
a systolic murmur, but S1
a long systolic murmur. So S1, S2 heard. A long systolic murmur is present in the mitral area.
Apex.
Then there is an early diastolic murmur or diastolic murmur
in the sternal border.
Sternal border. Okay.
Left sternal.
You ask the patient to sit up and lean forward.
While auscultating initially, the patient was in a slightly sitting up position.
Okay. So what do you think? Somebody is having a wide pulse pressure who is having a diastolic murmur in the neo-aortic area or subaortic area with a systolic murmur in the mitral area. So what do you think?
So we can, it is an AR with
AR with
MR
flow murmur in the
okay, it has to be more like a flow murmur in the mitral area, and with a early diastolic murmur or diastolic murmur with a wide pulse pressure, more in favor of a aortic regurgitation. Okay.
So this was a system examination.
Okay.
So
what will be the like you have a flow murmur here? Do you think that this patient is in failure clinically? How do you know that patient is failure in clinically in AR patient? AR patient, what will happen to the ejection fraction normally? if you do an echo, what will be the ejection fraction?
During systole, there will be more pumping.
So it's a supra ejection fraction phenomenon. So the pumping is more. So most of these patients will never have a low BP, so low systolic BP. What are the clinical features of a failure in a patient who is having AR? Failure, heart failure.
Elevated JVP, pedal edema, crepitation.
In BP.
BP.
Systolic decapitation. That is, word is given systolic decapitation. That means low systolic BP in any of the AR patients. If you are getting like that, then you have to think about failure. There are other reasons like associated AS can produce reduced systolic BP. But as an emergency doctor, if you are seeing an AR patient, if the BP is low, systolic BP is low, then you have to think about a failure. Okay. So the failure will present with systolic decapitation. The same thing can occur in aortic stenosis. Okay.
So this patient is currently like a diagnosed case of infective endocarditis with a probable AR and it is like a native valve disease.
Okay. So fresh valve, not a
prosthetic, not on a prosthetic valve, and currently not in failure and has no associated complications. So ideally
So what may be the reason for aortic valve which is involved? As per the clinical finding, I am not telling the echo finding. What are the reasons an aortic valve is involved in infective endocarditis? Which all cardiac lesions are prone to develop infective?
High jet lesions, basically regurgitant lesions, then any congenital lesions.
So he is a young patient. What are the conditions where you can get AR in a young patient?
Bicuspid.
Bicuspid aortic valve is one of the common cardiac lesions, but early infective endocarditis in bicuspid aortic valve is not very common. Marfan's. So if the patient is having Marfan's habitat, that means very tall individual, they are more prone for this type of problems. Any patient can develop infective endocarditis if there is a congenital lesion, that we don't know. But Marfan's is the patient is having
No,
Marfan.
patient is not very tall and he's like
average.
a short average habitus only. Then other Marfan features were not there.
Okay, syphilis.
Syphilis can
Syphilis
cause
is another
AR.
cause AR, but it is not common nowadays. So we cannot tell that it is syphilis, but syphilis can present with AR. Okay.
Then the congenital lesions like any TOF or something.
Okay. So congenital lesions can be there, but this patient was asymptomatic. Suddenly developed all these problems. Okay.
Echo is where was the lesion?
Echo basically he had a mitral and aortic. Both
valves are involved.
Vegetations.
Okay.
Then so it was like echo when it was a bicuspid aortic valve with the severe AR and moderate to severe MR with vegetations. And there was good LV function and dilated LV with a normal left atrium.
Okay.
So that was the echo finding. So since this patient came to our ER, so we had involved the cardiology team and he was kept on O2 and other antibiotics. Empirical antibiotic was given.
Now next is you have to stabilize the patient. You have to investigate the case. How do you stabilize the patient? How do you investigate the case? What is his symptom? That is very, very important.
This patient, fever was the only
symptom. So you
symptom.
have to give complete paracetamol and complete coverage of fever. Okay, there should not be any fever after admission. Why we are worried about fever in all these conditions?
Fever will cause tachycardia.
Okay.
So tachycardia will reduce the diastolic time. So it will further worsen the AR.
AR part, it will be worsened. Okay.
Then other thing is the
what happens to the findings of AR in a case who is having MR? This patient you told MR is also there. What will happen to the peripheral findings in a case who is having AR? That we MBBS time we know that there are a lot of some 16 signs are there in AR. What happens for that signs in a case who is having associated MR?
It will be reduced.
All peripheral signs will be masked by a previous lesion like mitral stenosis or mitral regurgitation can mask all the peripheral. That's why we don't get any peripheral signs here. Okay.
This patient, like how to investigate is like we'll have to get the blood test done.
Blood culture is very, very important.
Thing.
How do you take blood culture?
So 3 or more cultures should be taken, and minimum interval between the first and third culture should be like at least 1 hour, and the culture should be taken from different sites.
Why you are wasting so much time and energy to do like this?
Bacteremia, like the blood. Like
so you want to prove that there is a continuous shed of bacteria from the heart. Continuously bacteria is thrown out from the heart. So you want to prove that. Or suppose only one sample is positive, then it can be contamination, like some staphylococcus. So it can be contaminated. To rule out that, so you want to double confirm that there is a continuous flow of same type of bacteria in different time. That's why we are taking so much pain and taking 3 or more samples.
So
that is for diagnosis. What is surveillance cultures in endocarditis?
Once we start the antibiotic, we have to take at least 2 cultures every 24 hours.
48 hours. 24 to 48 hours. You have to repeat until it becomes negative.
Negative. That is culture is one important thing. Then other is echocardiogram we have to do. If we are not getting in the thoracic echo, but we have a strong suspicion of infective endocarditis, then a transesophageal echo should be like warranted.
They are seeing something, but the patient is not febrile. What can be the differentials? You're seeing some foreign body in the valve, things like that.
It can be due to other conditions like SLE or carcinoma, marantic endocarditis. Then Lippmann-Sachs endocarditis, like an SLE. Then it can be
myxoma. That is one important condition.
Myxoma.
What will be the clinical finding in atrial myxoma? That's not an acute condition. They have for a long time.
It might present with syncope.
Syncope is the most important thing. So positional syncope, they have developed syncope on certain positions. Okay.
So blood culture is one thing.
I mean, we are still in echo. So if you are not getting in what will be the indication for a transthoracic echo? Sorry, transesophageal echo.
One is transthoracic echo is negative, but like blood culture, other things are positive. We have strong indication for IE. Then one is transthoracic echo is inconclusive. Something we can see, but it is inconclusive. Those things we have to go for transesophageal echo. Then other thing is like we have to look for any like complications related with this. Any neurological deficits, and then in abdomen embolism is common, so splenic embolism, anything is there. Then like all these things. Then hematuria, glomerulonephritis.
Common areas of embolism you are told. Spleen is one area. Then kidney is one area.
Then stroke
brain
can
is
happen.
Another area. Then
cutaneous embolism.
Fingers. That is one of the commonest problem. Fingers distal circulation can be blocked. Okay.
So all those
eyes.
So all those things.
These are life-threatening complications.
That's with the systemic complication. What are the local complications in the heart because of endocarditis?
It can cause microabscesses, then valve ruptures can happen, pseudoaneurysms can be there, then like fistulas, all those things can happen.
The presentation wise, heart failure.
Heart failure. Then other evaluation part is this much important thing is blood culture, then echocardiogram. Then other thing is the Duke's criteria we have, the diagnostic criteria. So that has basically the major and the minor criteria, and we can say it is definitive, possible or rejected, whether these things. So major criteria is basically the blood culture and the echo findings. Minor criteria is any pre-existing like possibility, the other things, fever, then the immunological signs like Roth spot, Osler's nodes, then vascular abnormalities like microaneurysms and splendour hemorrhages, all those things, and the other echo findings. If there is like obvious large vegetation, the abscesses, then rupture and all those things, it is major criteria, but other possible vegetations and all are minor criteria. So based on that we can say whether it is a like a diagnostic thing. Then other thing is the routine blood tests we'll have to look for, because anemia is closely associated, like as a triad, like anemia, fever and
Anemia, how do anemia develop in infective endocarditis? It is due to hemolysis, whether it is intravascular hemolysis or hemolysis occurring in the large spleen. Both are it's mainly due to hemolysis.
Then other thing is any like urine hematuria, the glomerulonephritis features that we have to check for. Then like all other routine blood tests, all these things are required. Then we'll have to ideally the patient, if having any complications, should be treated in a like a hospital with the endocarditis team. That is the terminology that we use. That is the hospital should have the cardiology facility, cardiothoracic surgery facility with a good infectious disease team, having facilities for transesophageal echo, then any other procedures, then neurological like endovascular procedures and all these things, including neuroimaging. So if a patient is having any complication features like a failure or any neurological symptoms, I think ideally the patient should be in such a facility. Then the patient like when to involve a thoracic surgeon is another thing.
That is a secondary thing. As emergency doctors, we have to start antibiotics.
So antibiotics, basically empirically we can start the patient on a like a combination covering a MRSA also, sir. So we can start on ceftriaxone 2 gram IV stat along with vancomycin 15 mg per kg dose, because it covers gram negative and positive along with MRSA.
Okay. So if you take ceftriaxone, vancomycin, all textbooks are going once daily dose will be enough. Okay, all textbooks says. But most of the physicians believe that it should be divided into 1 or 2 doses and should be given. They want to maintain a continuous level of ceftriaxone, vancomycin in the blood. But textbook says it's a single dose. Okay.
So ceftriaxone, vancomycin can be empirically started from ER, sir. So ideally before that we have to get the cultures, because sometimes we like a partially treated thing and all, we will be getting a culture negative.
Okay.
So that is one thing. Then
what's the recommendation for prosthetic valve?
Prosthetic valve, like initial period it will be start after like 2 years and all, it will be
empirical antibiotic. I think rifampicin is also there.
Rifampicin also can be added. So the organism is another thing. Like organism, common thing is streptococcus. Then there can be like staph can happen. Then Hastek organism is rare, but it can happen. Then gram negative other organism except the Hastek.
Basically in ER we have to cover both gram positive and gram negative. It's all infection. Empirical therapy means cover gram positive and cover gram negative. So in infective endocarditis we give ceftriaxone for covering gram negative organism, vancomycin to cover gram positive including MRSA. So if you start that, it is on the safer side. Then once you get the culture report, you can switch down or switch up. Okay.
So in this patient, like the cultures taken from our hospital was all negative, because probably the patient was already on ceftriaxone and gentamicin from other hospital, maybe because of that. And since the patient had like severe AR and MR and was going into failure, like they had and also the patient had a anterior mitral leaflet abscess with perforation.
Okay.
So the patient was taken for surgical correction of both the valve thing, and even like they had sent the tissue also for culture, which also came out to be negative.
Okay.
That tissue culture was also negative. Then he had a bicuspid aortic valve. Maybe secondary to that he might have developed
why he developed infected endocarditis? Only because of bicuspid?
Other lesions, like
no other immunocompromise?
Nothing was there, sir.
No IV drug abuse?
No history of IV drug abuse or anything.
Usually we say IV drug abuse for right-sided endocarditis. So anything else in right-sided endocarditis which you need to remember, especially in healthcare setting?
Staph will be common. Tricuspid.
Risk factors, indwelling catheters. Okay, central lines. That again predisposes to right side.
Then what happened?
And the patient like underwent surgical correction.
What surgical correction they advised?
like the bilateral valve surgery.
Valve replacement.
Replacement
Repair
surgery.
or replacement?
Repair was done.
Okay.
And after that, the patient had developed a like complication of mycotic aneurysm rupture, leading to a.
What is mycotic aneurysm?
That the bacteria, this emboli can go to the brain and it causes the aneurysm of blood vessels.
Okay.
And it can lead to IC bleed. So it's a neurological complication of.
Okay. What are the common complications of infective endocarditis?
Sir, it can be like neurovascular. Important thing is heart failure. It can
Cardiac failure. Arrhythmias, cardiac failure.
Cardiac failure. Then neurologically, there will be TIA, stroke, mycotic aneurysm, brain abscess. All these things can happen. Bleed and all. Then the renal dysfunction, glomerulonephritis, that can happen. Splenic emboli causing infarct and can happen. And splenic abscess are rare, but it can happen. Then peripheral.
In fact, how do you diagnose?
Splenic rub.
Splenic rub. Main thing is pain. Tenderness, then rub.
Then peripheral, like emboli can cause vascular compromise, gangrene, cutaneous gangrene and all.
Renal failure? Renal failure, glomerulonephritis, all can be produced.
These are the common complications.
Okay.
What are the recommendations for this oral anticoagulation in a prosthetic valve with endocarditis? So usually there is a recommendation to withhold oral anticoagulation and when the patient is having an active vegetation for surgery, and even after that it is cautious anticoagulation because of the IC bleed and things like that. So that is one area where anticoagulation can be held on. What's this dental caries and endocarditis? What's the usual correlation?
This dental procedures and there will be local flora will be there, so it can predispose to endocarditis. So in patients who are predisposed to endocarditis, we recommend the prophylactic
what are the cardiac
antibiotics.
lesions are least chance for infective endocarditis?
MS, ASD, stenotic lesion, ASD, low jet lesions.
Low jet lesion. MS and
ASD.
Okay.
So they are low jet lesions.
Okay. AS is high jet lesion.
ASD.
ASD is a low jet lesion.
Then so in this dental procedures, then all the intervention, any bronchoscopy, all these things, if the patient is predisposed to infective endocarditis, like cyanotic congenital heart disease which is not corrected, any previous infective endocarditis, all those things, a prosthetic valve, all those patients.
This patient might have had AR prior to this, so we don't know. He had any dental procedures?
No history.
What is the difference between infective endocarditis prophylaxis and rheumatic fever prophylaxis? Both are same or both are different?
Both are different. Rheumatic heart disease is like for a prolonged period. IE is just before the procedure.
Okay. So, what are the major procedures you are worried about infections?
One is this dental procedures, then bronchoscopy, genitourinary procedures, endoscopy.
So again you can divide above diaphragm procedures, below diaphragm. Above diaphragm it is mostly gram positive infection. Below diaphragm it is mostly gram negative. So that like that your coverage also. Above diaphragm it is amoxicillin. Below diaphragm?
Clindamycin.
It is gentamicin.
Gentamicin. Above diaphragm amoxicillin, ampicillin or clindamycin. Below it's gentamicin.
So that has to be, but we are more in emergency room. We should be very careful when we are putting catheter. We are doing any urinary procedures, all these things. For a dentist, it is very important that dental procedures they should give antibiotic coverage.
What are the usual indications for surgery?
Valve surgery. That is development of any complication. Then persistent bacteremia, then. Failure, rupture, persistent.
Heart failure,
rupture,
valvular issues. Then if you have a left-sided endocarditis with Staph aureus or fungal. So fungal endocarditis is an early indication for surgery is there. Any mobile vegetation more than 1 centimeter again is an indication. And as you told, persistent bacteremia in spite of antibiotics. So if you have a culture negative endocarditis, is there any other way of you can try to find it out? Any other test?
PCR, that is basically during valve surgery we can take a PCR.
PCR or serological test also can help. at times to diagnose.
Okay.
Okay.
Thank you.